Hello, everybody. My name is Naveed Sattar. I'm Professor of Metabolic Medicine at the University of Glasgow. I was privileged to be at the American Diabetes Association early in June, and here are some Congress highlights. Before I talk about them, here are my disclosures of interest. So, the American Diabetes Association Congress 2022 was a hybrid meeting with 900 live presentations, more than 1,200 published posters, and over 80 exhibitors. And there were more than 1,400 original research presentations given and over 180 sessions. So it was really packed full of lots of new material, lots of revisions of old material, and really quite a lot of new science and interactions. I'm only going to present sort of 3 or 4 areas because I think I got a sense of what was really quite important. On Saturday, there was a session called NAFLD and Diabetes, an overlooked complication ? In the diagnosis and emerging therapies stream. So there was a new treatments of NAFLD presentation by Jay Horton, who is a physician who comes from Dallas, Texas, who's done quite a lot of work on the molecular aspects of NAFLD. So Jay Horton reminded us that NAFLD, effectively is non-alcoholic fatty liver disease. It's diagnosed when patients have excess fat beyond about 5% liver fat. More often than not, it's diagnosed by ultrasound, occasionally by MRI, and in many cases, actually, it's diagnosed by the finding of raised transaminases. Apparently, based on hepatology literature, 20 to 25% of the population have NAFLD. I'm not quite convinced it's to that level, but that's what hepatologists tell us. Jay Horton reminds us that the key development or underlying pathophysiology is insulin resistance, such that fatty acids are higher in the circulation and enter the liver. And in the context of excess calories, hyperinsulinemia leads to lipogenesis in the liver. So effectively, if you have insulin resistance and high insulin levels and you still overeat, insulin will direct some of those excess calories to fat storage within the liver, and that's what effectively causes NAFLD. So it's effectively ectopic fat linked to excess nutrition. He reminded us that simple steatosis, which is NAFLD, can progress to NASH when there's steatohepatitis, so there's a degree of inflammation, and with furthering of fibrosis, you can get to a point where the liver is so scarred it becomes cirrhotic, and that, of course, is a big problem. Can have major implications for patients' quality of life and other complications, and eventually can lead to cancers. Drugs can be, or interventions, both lifestyle and drugs, can happen at different stages. And he told us that actually at the moment, whilst there's many trials going on in this area, many drugs have failed, and that he thinks going forward, what we might need is drugs, multiple drugs targeting different stages to have impact. He covered ongoing and recent trials. So I think one of the major themes was drugs that cause weight loss. So we have the GLP-1 receptor agonists and semaglutide, which I'll show you on the next slide, causes substantial weight loss. Tirzepatide data have also come forward in a recent paper, I think in Lancet Diabetes and Endocrinology. So it's a GLP-1 receptor agonist with a GIP dual agonist. And there was, I'll show you some data towards the end in the SURMOUNT trial. There is also interest in NAFLD in long-acting FGF21 and FXR agonists, but these are quite early on in trials, and plus many other potential agents that affect different parts of the triglyceride pathway or weight loss pathway. He did, however, remind us that it's not all about drugs, and that actually lifestyle can lead to benefit. So he reviewed 8 randomized trials, which nearly 400 patients, and effectively showed that those patients who lost more than 3 to 5% weight loss did improve the steatosis, their fatty liver disease. And I can tell you clinically, that's exactly what I see in my clinic. When patients lose, say, beyond 3 to 5 kilograms or 3 to 5% weight loss, we can see improvements in liver function, ALT, gamma GT, improvements in triglyceride levels. And often, if they've also got dysglycemia, we can see, modest improvements in the hemoglobin A1C levels. And I have a paper coming out in Circulation that pulls all these clues together and explains how there are many clues that we see in our clinic that tell us about ectopic fat, not just in the liver, but also in the circulation. Going back to Jay Horton's talk, he really centered on the semaglutide trial, which was published by Philip Newson and colleagues in the New England Journal last year. So it was a phase 2 trial 3 doses of semaglutide, as you can see, 0.1, 0.2, and 0.4 milligrams of semaglutide, and they also had a placebo arm over 72 weeks, and the results were encouraging. What did they show? Excuse me. On the left side, I think, is the key result. They had 2 different sort of groups of endpoints. So they looked at the percentage of patients who had resolution of NASH with no worsening of liver fibrosis. And here you can quite clearly see in all 3 arms, there's a significant improvement, particularly in the semaglutide 0.4 milligram arm, of an improvement in people with resolution of NASH, but no improvement in fibrosis, 59% compared to 17%. So more than, and it's kind of an odds ratio of 6.87. So that's quite substantial improvements in that endpoint. However, if you looked at the improvements in liver fibrosis stage with no worsening of NASH, well, there was no clear difference in the semaglutide arms compared to placebo, no significant differences. So at the same time, you could also see improvements in ALT, which is a surrogate marker of liver fat. I use this all the time in the clinic. And I think, you know, if you look at the ALT levels, they're kind of high normal, just so it depends on your upper range of normal, but ours is around about 50 in our hospital. So it's probably around about here. So just, you know, some of these individuals would have relatively what's known as within the normal range, but nevertheless, look, a clear dose-dependent reduction in ALT levels compared to placebo, and almost a halving in the semaglutide 0.4 milligram arm. So that's really quite impressive, and that's in keeping with the reduction of liver fat. So Jay Horton concluded that, you know, these trials and the authors concluded that semaglutide certainly improves steatosis, but not necessarily fibrosis. There are also, Jay Horton reminded us that other drugs being tested that, you know, block de novo lipogenesis. So this is, I'm not going to go through it in any detail, but the pathway to triglyceride production within the liver and storage is really quite complex. And there are many drugs that have actually, that target this pathway at different levels. Some early failures, however, because while some drugs theoretically should have improved hepatic steatosis, they also led to a secondary effect of increasing circulating triglyceride levels. So the mechanisms are more complex than originally imagined. And it may be this is why Jay Horton said targeting dual pathways may be needed, but clearly more trials are needed to investigate this further. So watch this space. My current and overriding opinion is that actually significant weight loss is probably going to be the best and the safest option to prevent patients progressing from NASH to cirrhosis and so on, or even from NAFL to NASH. So I think my personal opinion is that significant weight loss, and we have now a few new tools coming, both lifestyle and newer drugs, may be the way to go. But let's see how this field evolves. Quite a lot of interest. I think probably the greatest interest in the whole conference was really about obesity, and obesity is, you know, should it be the primary target of treatment? And there was a debate. Ilde Lyngve was the kind of promoter of the debate, the pro from Dallas, Texas, who's you know, she's a friend of mine, and she's an excellent physician in Dallas. And Ilde reminded us that obesity is upstream of type 2 diabetes. She discussed that there's a personal threshold of obesity for ectopic fat. So, for example, if you look at me, I'm South Asian male, I have a family history of diabetes. So my threshold is going to be lower, so that at lower body mass index, I will put fat into the wrong places compared to somebody, say, who is white, or woman with no family history, who can put on a lot more weight before it goes into the ectopic stores. She also reminded us that excess adiposity causes many consequences through mechanical effects, through metabolic effects, through effects on risk factors and other factors, and that excess adiposity is associated with more than 250 conditions. It fuels disease and it fuels diabetes. And also she reminded us that the impact of weight loss, if you were able to get your patients to lose weight, depends on where these patients start. So she highlighted the paper, a recent paper that she's published in The Lancet, and it's certainly worth a read. It's an excellent paper which promotes all of this concept that, you know, adipose, I can't even say that word, but you can, adiposopathy. Anyway, you can work it out. It's effectively excess adipose tissue in the wrong places, and it's completely aligned with insulin resistance, and also drives hyperglycemia, but also, you know, beta cell function probably declines as diabetes progresses. But The point she was making that in the context of prediabetes, improvements in weight can lead to resolution of diabetes or prediabetes and prevention of diabetes. Once patients have early diabetes, weight loss can lead to resolution of diabetes and prevention of complications, although that needs to be proven in randomized trials, which are currently ongoing. But if you have a patient who, say, has had 20 years of diabetes and they've got complications, it may be that their weight loss is not necessarily to have resolving diabetes, although it might happen. It's more perhaps to stabilize or improve or lower the risk of complications. So it depends on the patient in front of you to the degree to which lowering weight will have benefits for that individual. Clearly, even before patients have any evidence of dysglycemia, if you resolve excess weight, you will prevent even patients progressing to prediabetes. So again, depends on the stage the patient's at. She reminded us from the diabetes prevention program that every kilogram loss was associated with a 16% reduction in development of prediabetes. And then, of course, she then reviewed the evidence of diabetes remission is possible with weight loss, even in early diabetes. So in the Look Ahead trial, 11% patients had diabetes remission. This is a trial that many of you know was intensive weight loss to try and prevent cardiovascular outcomes. Now, they didn't prove cardiovascular outcomes in the whole trial, but nevertheless, 1 in 9 patients had diabetes remission, which is, again, that's pretty decent, actually. However, she also then argued, based on the DIRECT trial, that there's even better evidence for weight loss and remission. And the DIRECT trial is a trial that came out of Newcastle and Glasgow, and I was involved in this as one of the co-investigators. And this is what we reported. Mike Lean was the first author, Roy Taylor, senior author. And effectively, in the intervention arm, the more weight that was lost, as you can see, up to 15 kilograms weight loss in the intervention arm, both at 1 year and 2 year, you had somewhere on average between 70 to 85% diabetes remission, which is really remarkable if you think about it. Now, these are patients with diabetes on average about 3 years duration, so this is relatively early on. But if you remove weight, and further data from the DIRECT trial shows you can remove liver fat, you can also improve blood lipids, you improve beta cell function in those who have remission, and blood pressure and other risk factors. So then, AOD then went on to look at data from bariatric surgery and highlighted the data from Mingrone et al., which they first published these data in the New England Journal 2012, and they now have almost a 10-year follow-up published in the Lancet. So this is intensive medical therapy, led to about 7 to 8 kilograms weight loss, and then 2 types of surgery, substantial weight loss around about 30%. And as you can see on the right, if you look at the glycemic levels, which are quite high to begin with, 8.5 to 9%, substantial improvements in glycemia in the surgical arms, more so in the kind of biliary pancreatic diversion procedure than the Roux-en-Y, but nevertheless, both fall below the diabetes range, particularly in those in the BPD arm. Look at that average hemoglobin A1C down to about 5%, and even after 10 years, it was around about 6.2 or 3%. So the vast majority still no longer had diabetes in this particular group, which is, again, suggesting excess weight is the cause of diabetes, even in patients, regardless of how you manage to cause that weight loss. So weight loss equals glycemic control and substantial glycemic control, but Dr. Lingui reminded us that it's also improvements in CV risk factors. So you get big improvements in lipids, systolic blood pressure, and inflammation. In the Look Ahead trial, she reminded us, although it was a post-hoc analysis, therefore you've got to treat it with caution, that those patients who lost more than 10% weight loss, was associated with a 21% lower risk of major adverse cardiovascular events. And the same was seen for bariatric surgery. Beautiful paper by Aminian et al. In JAMA. Big weight loss associated with substantial reduction in cardiovascular outcomes and a number of other outcomes that we and others have shown. There seems to be an association with lower renal outcomes, lower heart failure, lower MACE. So significant weight loss seems to be associated with big improvements in cardiorenal and atherosclerotic outcomes. Having said all of that, none of these are definitive because none of them are proper randomized trials. Although the 10-year follow-up of Mingrone et al. Is supportive and has got some data, although it's post-hoc. What does it show? Well, if you follow those patients who had bariatric surgery compared to medical therapy, look at the 10-year diabetes-related complications. Overall, about 3/4 of patients in the medical arm who only lost, less than around about 5 to 8 kilograms, if I recall, 75% had some kind of complication. 11% cardiovascular, 61% microvascular. But look at the surgical arm. Only 5% had microvascular complications. And that's in keeping with the fact that the glucose is almost normalized in the vast majority of patients. So that's fantastic data. But equally, look at this, the quality of life of patients substantially improves if you lose significant weight loss. So compared to medical therapy, the closer these dots are to this outside, which is 100%, the better is the improvement in functioning. But so slight, not bad in medical therapy, slight improvements, but look at those two surgical arms, substantial improvements in physical functioning, bodily pain, vitality, emotional role, general health, social functioning, mental health was also seems to be improved, and the total score was, again, improved compared to medical therapy. So I think that's very exciting data. Therefore, obesity, or the other word I can't really say, but I'll leave you to it. Before even lots of patients get hypoglycemia, they have lots of other complications linked to excess adiposity, sleep apnea, non-alcoholic steatohepatitis, arthritis, hyperlipidemia, hypertension, coronary artery disease, etc. And a weight-centric approach upstream should prevent all of these problems, whereas a glucocentric approach will only effectively affect the downstream complication. And that was her arguments. The contra was done by Jeffrey Mechanic, who's from New York, and he basically said glucose control, well, he was tasked with argument of glucose control should be the primary target of treatment. And I'm not going to go through this in any detail, just one slide. And the reason it's only one slide, because he really didn't have a strong argument. I think Jeffrey, he said himself, he could easily have argued the other side very nicely. And therefore, most of his debate was philosophical. And really, I found it, I was there, very tricky to follow. He did, however, remind us that don't forget glucose lowering, even if you do it late, late in the course, does prevent outcomes. And meta-analysis of randomized intensive glucose lowering randomized trials, which we and others have published, shows that if you reduce hemoglobin A1C, however you improve it, even with drugs that don't improve weight, you can reduce MACE by around about 15%. Well, at least in the meta-analysis. Whether some drugs like sulfonylureas do reduce MACE is not yet been proven, and DPP-4s, it shows not to be proven at the moment, at least in 5 years' time, although they will prevent microvascular events. But Dr. Mechanic did, however, agree that weight loss should be a primary target in diabetes, and new guidelines are starting to recognize this. So effectively, I think he tried to do his best. It was too philosophical, and effectively, I think, agreed with Dr. Lingavay that, and also the ADA-ESD, which has now come up with a conceptual proposal, which has not yet been finalized, that they want to promote both hyperglycemia improvement and weight loss as key equal targets in the treatment of diabetes. So weight loss initially it's equal importance to glycemia. So this is a big change from even 2-3 years ago, is now recognizing the real importance of excess adiposity in diabetes. And if that now becomes new guidelines, you can see how there's going to be much more greater concentration on obesity in the management of diabetes early on in the course of diabetes. The final talk I want to present was the SURMOUNT-1 trial. It was the results of the first phase 3 obesity trial with tirzepatide, which is a novel GIP, GLP-1 receptor agonist. And it was presented by Ania Shasharboff and Sean Wharton and several other colleagues. And I'm not going to go through it in detail, I'm just going to give you the top line. Trial design, 4 arms, it wasn't in diabetes, it was patients with obesity, some of them who had pre-diabetes. So 4 arms, placebo, tirzepatide, 5, 10, and 15 milligram doses. 2,539 patients, greater than 18, BMI had to be above 30, or if there was above 27, they had to have one of the following: hypertension, dyslipidemia, obstructive sleep apnea, or cardiovascular disease. Randomization was stratified by country, sex, and pre-diabetes. The durations were 72 or 176 weeks. And they tried to include at least 30% men, just because generally most weight loss trials, it's women who tend to go to weight loss trials, but men are, men actually for the given weight have higher risks of every complication nearly, because they carry more fat ectopically. During the first 72-week period, one study dose reduction was permitted per patient to help manage intolerable GI symptoms, and I'll come on to symptoms in the next 2-3 slides. Primary objective % weight change and the percentage who lost more than 5% weight loss. But actually, as you'll see, many patients lost much more than 5%. The results were published in a paper that came out at the exact same time as the talk in the New England Journal of Medicine. And if you look in the kind of treatment regimen estimate, in those patients in placebo, 3.1% mean weight change, but look at the 3 tirzepatide arms, 15, 19.5 and 20.9 percentage change in body weight, which is really quite substantial. And you can see how these weight changes occur over time. Again, placebo, 5 and 10 and 15 milligrams, and here's the kind of percentage changes. That led to, if you look at the kind of the treatment regime estimate, so this is really the intention to treat, almost 90% in the high dose reached more than 5%, but look, 83% had more than 10% weight loss, 70% had more than 15% weight loss, which is substantial. And actually 36% had more than 25% weight loss. And then if the numbers were high, if you look at, this is known as the efficacy estimate, this is almost the completers of those patients who completed, almost 4 in 10 had more than 25% weight loss. So this is a very powerful weight loss drug to the likes we have not yet seen in clinical practice. They also showed improvements in body composition, glycemia, insulin, liver functions, systolic blood pressure. So total fat mass fell by almost 34% compared to 8% in placebo using DEXA. However, lean mass did fall more with tirzepatide, 10.9% versus 2.6%. So you do lose lean mass, whether that's pathological but we do know lean mass is lost with any degree of weight loss. So, but it's something just to watch out for. The hemoglobin A1C was only 5.6 at baseline on average, so not much room for improvement. But what they did show was, again, a significant improvement in glycemia in the tirzepatide arm compared to placebo, such that more than 95% reverted to normal glycemia in the pre-diabetes group. Insulin also declined by 47%, ALT, which was not high to begin with, declined by 7 units, if I recall correctly, and also big reductions in systolic blood pressure from an average which was not that high, 123. Again, suggesting, I think that reminds us that actually blood pressure levels with obesity do go up, and that even modest levels, which we used to consider modest, are higher than they should be because of patients carrying excess weight. So something again to watch for. Safety, this is important. There was more nausea, diarrhea, and constipation in the intervention arm, about 3-fold, but these generally did settle over time. You get most of these effects when you start the drug or when you change the dose. And so the mantra for GLP-1 type of class is start low and go slow with dose escalation and give good education to patients. And I think that's, that would mitigate side effects. Vomiting was high, 12% in the tirzepatide arm versus 1.7 placebo. Again, that did settle over time. There was a little bit more hair loss, which happens with even bariatric surgery. So that's something, again, to watch for. Slight excess dizziness, but there was no difference in gallstones, cholecystitis, or pancreatitis. And overall, the colleague who was tasked with talking about safety, his comment was, overall safety was similar to other injectables in the GLP-1 class, because you do see this, although I think they're probably, well, I haven't, none of us have done a head-to-head comparison, but perhaps greater weight loss leads to slightly more side effects initially, but they do settle over time. That having been said, there are outcome trials coming, and we should watch for these. So my summary of the ADA 2022 was that actually there was a big focus on weight loss. So it captured the importance of obesity and diabetes as the major risk factor for developing diabetes through pathways linked to ectopic fat, but also it showed us that there was new horizons in weight loss coming. We already got tirzepatide and high-dose semaglutide. I should remind you that there are outcome trials for tirzepatide to ensure safety is coming in 2024, so we need to watch for this. Same for semaglutide. The STEP trial is coming soon. But also that the ADA and ESD guidelines, they've put a proposal to emphasize weight control more in the management of people with diabetes. So a real major shift coming in the treatment of diabetes and new tools to help us. not just drugs, but also lifestyle based on things like, the low-calorie diets which we showed in the DIRECT trial. Also remind you that weight loss is relevant to NAFLD because excess fat in the liver is part of the pathogenesis of diabetes and to other complications. So my sense is the ADA 22 will be remembered as a conference where weight loss benefits featured heavily, and that really obesity management hit the headlines. So really a big paradigm shift in the potential treatment of diabetes going forward, but we'll see how this tracks out into clinical practice over time. The issues are going to be, of course, newer drugs are more expensive, they do cost more, so guideline makers have to be cognizant of this, and certainly pharmacies have to be cognizant of this. We cannot afford to treat all the patients we would like with these drugs, and we need a bit more safety data, but these are coming in multiple ongoing trials, particularly cardiovascular outcome trials, although there is some early evidence of cardiovascular safety for GLP-1 class in general, in fact, even improvements in cardiovascular safety, and early evidence that tirzepatide is at least safe in cardiovascular outcomes, and there's ongoing trials. So watch for more trials to come, STEP, SURPASS, CVOT, and multiple other trials from 2023 onwards, and these will help further define and shape the field in terms of obesity and diabetes, and in terms of to what extent we now start to shift our focus away just simply from glycemia more to weight loss in the management of diabetes. I will stop there. Thank you very much for listening, and I hope some of this was useful. Thank you.